Very good afternoon to respected teachers and my delegates. Today I am going to present applications or investigations in post-segment trauma. So I have no financial disclosure in this presentation. The type of post-segment trauma may be blunt trauma, the penetrating trauma, perforating trauma, or intraocular foreign bodies. So post-segment investigation, in case of media clear, we can go for FFA, OCT, ERG and BEP. But in case of media is not clear, we can go for B-scan ultrasound, CT scan, MRI, ERG, BEP. But I will discuss in this case only for the media, if the media is not clear. So blunt trauma can cause vitreous hemorrhage, posterior vitreous detachment, or peripheral retinal dialysis, retinal tear. So retinal dialysis can be seen in ultrasound. In the this is first picture is these insertions of the peripheral retina in the longitudinal ultrasounds, and this is the inverse ultrasounds. You can see that in these insertions of the retina. So thickening of the retinochoroidal layers can be seen with the help of ultrasounds also. On ultrasound, the sclera in the area of the rupture may show a moderately irregular contour or decreased reflectivity, although an actual split in the skull fiber may not be detectable. So in this pictures, you can see that this incrustation of the retina and the retinal detachment in this inferiorly. Here you can see the skull rupture area showing with the red arrow. So indirect indications of skull rupture in ultrasound you can detect with these few points, that is vitreous incrustation into the fundus associated with the vitreous hemorrhage and posterior vitreous detachment, thickening or detachment of the surrounding retina or choroid, hemorrhage in the immediate episcleral spaces. In case of optic nerve avulsion, you can see the vitreous hemorrhage surrounding area of the optic nerve, and in ultrasound you can see the low reflective area is not reaching up to the optic nerve face, and the surrounding area of the high reflective echoes of the vitreous hemorrhage, moderate reflective echoes of the vitreous hemorrhage. So in case of penetrating injury, you can look for the vitreous tract starting from the penetrating area. So in some cases, the tract may lead to an intraocular foreign body or to a posterior exit wound, or thickening or detachment of the retina or choroid is typically present near the impacted site. Here you can see this is the vitreous tract, and along with this some focal retinal detachment. And here you can see this the attachment of that vitreous traction over the retinal area, over the scleral rupture area. So anterior penetrating injury that lead to significant vitreous loss often result in traction on the posterior retina. Here you can see in this ultrasound, this is the vitreous traction over the retinal area. Here this is the retinal detachment. You can correspond with the A-skin spike of this retinal high spike of the retinal detachment area, and other part with the vitreous detachment area with traction, vitreous hemorrhage area. In RD, retinal detachment develop at the site of penetration or subretinal hemorrhage often occurs after very severe injury. In addition, incrustation of the retina into the sclera wool sometimes can be demonstrated. Here you can see this is the total retinal detachment, and here the incrustation of retina over the exit wound area. So hemorrhagic choroidal detachment may also be found in the scleral lacerated cases. So the majority of the globe with the scleral laceration have an associated hemorrhagic choroidal detachment. You may find a dome-shaped lesion inferiorly. In this picture of the ultrasound, you can see this dome-shaped area of this choroidal hemorrhagic area. So sometimes you may confuse with a skull fold with the intraocular foreign body, because the skull fold usually give a high spike in A skin. So whenever there is a sudden decompression of the glove, there may be a collapse of the skull wall. So in that case, you can give this skull fold area. So this is the then we did the ultrasound after 1 week of that, after repairing of the exit wound. So entry wound, this diminution of this skull fold you can see in the second slide. In case of intraocular foreign body, the standard tests include echography, computed tomography, magnetic resonance imaging. The plain film radiography by itself is not an adequate modality, but it may be relatively inexpensive and readily obtainable, but it is grossly insensitive. In one study done by Watson A. and et al., the plain film radiography failed to identify the foreign body in 60% of the eyes with non-intraocular foreign body. So even when the foreign body has been previously localized with CT scan or radiography, ultrasonography should be performed for more precise localization and to determine the extent of intraocular damage. So typical metallic foreign body have an irregular shape, thus producing very high reflective spike of varying appearance on A skin depending on the sound beam direction. Here you can see the metal foreign body giving the shading effect towards the orbital area, and with the A skin corresponding A skin a high spike. And very small foreign bodies like less than 0.5 millimeter in diameter are very difficult to detect. Even it doesn't give any shading effect towards the orbital area, even though A skin in the low gain, A skin usually give the high spike. When sound wave pass through a spherical metallic foreign body, a portion of the sound wave reverberate within the object. You can see this spherical gunshot palette. Here you can see the reverberation of the echoes. And in the A skin, the gradual reduction of this reverberated echoes. So sometimes in this penetrating injury, you may confuse with the intraocular foreign body with the ear. These are the multiple high reflective echoes. So after say 1 week of that, if you repeat this ultrasound, you can see diminution of these high reflective echoes. It shows the presence of ear inside the intraocular region. CT scan provides easy recognition of intraocular air as occur in penetrating trauma. CT scan, particularly helical CT, clearly defines most radiolucent foreign bodies, including small pieces of stone, aluminium, and lead-free glass less than 1.5 millimeter, and copper and steel minimum diameter of 0.06 millimeter. So CT scan helps determine the exact location of foreign body if both axial and coronal views are used. So in this case, you can see the first penetrating area from the temporal side and this exit wound in the nasal quadrant, and the intraocular in the CT scan axial view. You can see the lodgement of the intraocular foreign body towards the orbital retroorbital area. So CT has become the method of choice for demonstrating the intraocular foreign body in an open globe. The advantages are high sensitivity, little need for patient's cooperation, no direct manipulations of the globe, ability to localize the intraocular foreign body. Optimal results are obtained by scanning in 2 dimensions with thin cut less than 1.5 millimeter. Disadvantage is not detect the fragments that are smaller than 0.7 millimeter in 1 dimension composed of wood lying adjacent to the sclera. So magnetic resonance imaging once only test capable of detecting small plastic or wood intraocular foreign, but it doesn't employ strong magnetic forces and consequently can produce the movement of the magnetic intraocular foreign body, cause further ocular damage. So it is to rule out magnetic metallic intraocular foreign body before doing the magnetic resonance imaging. So The MRI shows better resolutions and detections of optic nerve lacerations or avulsions at their intracanacular portion. And OCT ERG changes in the cirrhosis may be the increase in A wave and normal V wave during the very early phase of toxicity. It may diminish with, in the later stage, and later it is become distinguished. Visual level potential, Houtman found normal BEP as a single predictor for good postoperative visual acuity in trauma. So BEP main benefit is to support for clinical decision for deciding any surgical procedures. Thank you.